I'm Bruno Paiva from the University of Navarra in Pamplona, Spain. At IMS here in Toronto, we are presenting an abstract with data on endogenous and CAR-T immune profiling in relapsed refractory patients that were enrolled in the KARMA study that led to the approval of Ide-cel as one of the anti-BCMA CAR-T products available for patients with myeloma. I think it's important to look at immune profiles because we know that antigen escape is probably the most relevant mechanism of resistance, but it's not a universal mechanism. We also know and reported in the past that depth of response is very important, but again, it's not a universal mechanism of response or resistance because there are some patients that will always behave differently in terms of lack of a deep response and nonetheless long progression-free survival and vice versa. And we hypothesized that a better understanding of unexpected clinical behaviors could come from immune profiling. And in this study, we showed that indeed the patient immune status from the T-cell point of view prior apheresis can predict PFS. We also showed that by looking at bone marrow aspirates, for example, collected at month 1 after infusion of Ide-cel, that are typically being collected for MRD assessment. You can not only assess for MRD, but you can also look for persistence of CAR-T cells, the numbers, the CD4-CD8 ratio, and even some more complex phenotypes that are predictive of PFS. And then after 6-12 months after infusion, when CAR-T cells are no longer persistent, they are cleared over time, you can look at endogenous T-cell profiles or thereby try to identify signatures of immune surveillance versus immune escape that could help to better predict who are the patients that after CAR-T infusion, CAR-T expansion and response may sustain the response or by contrast lose the response and progress based on those signatures of immune surveillance and versus escape. And this is what we have shown in this abstract. The potential is there, and I believe that now this data should be reproduced in other studies, and if positive in other studies, we should come out with a way of standardizing it, making it easier from the routine point of view. That's the hypothesis, that instead of waiting for a clinical relapse, a new line of therapy or a modification on the ongoing line of therapy could produce better outcomes. So having signals besides antigen escape, beside MRD, that could guide who are the patients that are at risk of losing immune control over myeloma and therefore resume a new line of treatment or using drugs that could reactivate those immune cells, that will be highly attractive. But like I said, that needs to be implemented based, I would say, on more evidence and also tools that could make this very, very practical from the clinical laboratory point of view.